Okay, guys, good evening. I decided to finish really the aortic session before we go any further. Last two times we talk about how we size the aorta for the aneurysm for EVAR. We give some an example, and then next session we talk about cannulation of contralateral limb, and we talk about some tips and tricks. So now we're done with the normal anatomy, normal, Now we got a bit more advanced. How you deal if you have some challenging in the EVAR anatomy. It's a little bit more advanced, but guys, some of you are like a third-year fellows, so you'll be ready to graduate soon. So you have to know how to deal with this kind of challenging. So when we talk about challenging, the challenge could be in four areas when you talk about EVAR. The first challenge could be in the neck. And this is the most problem challenge we have most of the time. The second challenge could be in the aortic bifurcation, could be very narrow. We'll talk about it. The third challenge could be in the landing zone. You don't have good landing zone distal. And the last one is the access vessel. You have everything is fine, but external iliac artery are very small. So this is the mere challenging you can find when you do an EVAR. So let's talk about one by one, Most important, guys, you have to ask me questions because I don't know what your level. And there is no bad question, there's no stupid question. Any question come to your mind, you can ask me. Either you can ask me, I try to finish like one challenge and give you some time for a question, then you go to second challenge, and this way, write down your question, ask me this question. But please ask questions so I know, guys, you are interactive with me because I don't see you. All right, eye view is very important. This is what the eye view when you're dealing with the neck. The neck has to be at least 19 to 30. Even you can go to 32, but it's not good. The larger is the diameter, high chance of type 1 Indo leak. So the acceptable is 19 to 30. The length and angulation has to be up to 60. If you have up to 60 angulation, you need at least 10 to 15. If you have too much angulation, they need a longer neck. And the reason why when you have too much angulation, you lose part of the neck because of the angulations. So you need really to do a long neck if you have a bad angulation more than 75. Oversize, as I said before, 15 to 20. I prefer to go more to 20. And then you have to look for thrombus, and according to the eye view, should be a minimum thrombus and calcification. So this is what the eye view said. This is what you want to see, but it's not the real life. This is what usually you get. I mean, rarely we get a patient with an eye views. Most patients, they have a different problem like that. Neck is angulated, wide, no landing zone. So let's take first about the neck, which is the most difficult. What the challenge? You have 6 challenges with the neck. Could be short, could be tapered, could be a thrombus there, could be wide, could be angulated, and could be calcified. Let's start with the first one, the short neck. If the neck less than 10 millimeter, no way you can do standard EVAR. You need to do something else. Then you have to do a chimney, you have to do a BVAR, FEVAR, or you have to take him to surgery. Or if you decide to do an EVAR, you may have to do an endo anchors. But you cannot just put a standard EVAR. If you have 10 to 15 millimeters, then it is within eye view. You can use any EVAR, but it's better to use the one with a suprarenal fixation because the neck is still short. So you need something to give you more fixation. So when you do suprarenal fixation, your fixation doesn't depend only on the neck, infrarenal neck. It depends also on suprarenal neck fixations. Of course, there's some question about that strats can affect because they cover the renal artery or they cross the renal artery. They may deteriorate the kidney function. Nobody proved that. Some papers they showed that creatinine goes up, but not statistically significant. So should not worry about the kidney when the bare metal part of the EVAR cross the renal arteries. And nobody showed has a long consequences. The main issue really it comes if the neck dies in the futures, and you have to do an add like a BVAR later on. Sometimes it's very hard to get the PVAR or BVAR or branched or FEVAR through the renals if you have the bar metal stent covering the middle part of the renal. So this could be a challenge. This is the only challenging part of that neck. or using suprarenal fixations. If the neck is more than 50 millimeter, you can use any EVAR device. Then you have long device and don't care about suprarenal fixation. You can use with or without suprarenal fixations. Let's give you some tips. So if you have a short neck, 10 millimeters, what the advice? First, always try to deploy the device above the renal, because it's always easy to pull the device down. It's very hard to push it up. So always start deploying above the renal. Don't do it in the renal, because sometimes after you deploy in the renal, exactly the renals, you find yourself device will move down. Then you can't push it up. So always start above the renal. Then you have to deploy full stent, 2 full stent. If you deploy more, you cannot pull it down. But if you deploy 2 full stent, you can still pull the device down. And less than 2, the device is not opposing the wall, so it's not enough. So you need to deploy the 2 full stent and then pull the device down to your markers. And then you continue deployment. Then you put it in down position. You can do an angiogram before you finish, exactly, if you want to be sure. And the last thing, you can be deployment. So the only thing, guys, what I always tell my fellows that when you start the EVAR, don't do angiogram from the beginning. It will not help. It doesn't make any help. And if you do an angiogram and you put your marker and then you put your device, this marker where you mark the renal artery will be wrong, because all the devices has some angulation or aneurysms. So when you do an angiogram, before you put a device or before you put a super stiff wire, your landmark will change when you put super stiff wire or put the device, because there are stiff devices, stiff wires. So all the angulation will straighten up and all your landmark will be wrong. So there's no need to do an angiogram before you start, unless for something, looking for something else. If your pre-op planning is not right, you want question the links or whatever. But otherwise, if you have a good planning, you don't need an angiogram before deployment. Deployment. So what happened, you wait until you put the super stiff wire, you put the device. When device at the level of the renals, before you deploy, then you do an angiogram. And then you mark your renal, and then you start deployment. But don't do angiogram before you put the stiff wire and device. Okay, so what about if the neck is short, less than 10 millimeters? It's called the juxtarenal aneurysms. How we deal with that? Here we have 2 options. Either you need to get a landing zone, because you don't have a landing zone. So either you can do a chimney or do a EVAR. Or you can use endo anchors, because endo anchors is being approved for 4 millimeter neck. I'm going to talk about that later on. Or always you can do a surgery if patient is good fit for surgery. So let's talk about, I talked about that last time. I know if guys you still remember about lengths and the sealing zones. Not all the short neck are the same. And this is very important when you talk about short neck. The neck, what do you mean by neck? Length is the neck of the aneurysm is the length over which the neck diameter remains within 10% of renal diameters. This is a green area. What does that mean? That you mean the neck, you oversize 10 or 15 or 20%, and still any part of this here will be oversizing 20%. So all be like straight, will not be like a tapered. So this is called the green. This is a neck. Like this one, they are both short neck, because whereas a graft opposed aorta with 15 to 20% oversized, only this area here, it touch it, but it's not, we don't have 15 to 20%. And the same for here. So this is a long neck, this is called a short neck. But the problem, this both, we call them short neck, but it's a problem because they are completely different. The reason why we need to differentiate between sealing zone and the neck. So this takes us to the next thing, what is the sealing zone? Sealing zone is the length over which the correctly per high view oversized stent is circumferentially opposed against the wall graft, aortic wall. What does that mean? That means you put the graft here, oversized 20%, still the graft touching the wall of the neck. It may not oversize 20% or 10%, but still touching the wall, maybe like the same size even. As far as touching the wall of the neck, we call a sealing zone. If it's not touching the wall, then called no sealing zone. Like, so this 2 short neck here, the green, But look, the yellow is a sealing zone. Here you have a long sealing zone. Where this one, we have a short sealing zone. The yellow is here. When you come, the graph come here, it's not touching the wall. It's too far here. So the graph will not touch the wall. So there's no sealing zone here. So there's a sealing zone here, there's no sealing zone here. So two short neck, right, but they are two different ones. So when you have a short neck, long sealing zone, we call it a hostile neck. When you have a short neck and short sealing zone, we call it inadequate neck. Why is that? Why is that important? Because you have a hostile neck, you get a seal, but the seal is not strong enough. So you need to strengthen your seal. Here you have no seal, so you cannot even try the EVAR here. So when we deal with the hostile neck, you need to get some strength. You need to add strength to your repair. So you need to use an EVAR, then you have to add some strength. Here, you need to add a length because we don't have, so here we have a length, but we don't have a strength. So you need to add a strength. Here, you don't have a neck. You don't have a seal. This is why, so you need to add a length. So you need to do something here. We're going to talk about it here. Let's give you some example. This patient neck length is 20. And the sealing zone exactly the same. Also 20, 25. This is a sealing zone. Going all the way from up, all the way down, sealing zone. And this is a green, is a neck. So you have a long neck, long sealing zone. So this one, you just treat it normal. Just with an EVAR, work beautiful. You get excellent seal. Look at this neck here. You have short neck, 4 millimeter. But look, this is the green one. You see, it's very short neck. But look at the sealing zone. We have a long sealing zone, which is about 10 millimeters. So this one, when you put a graft, it's going to be touching the wall up to here, then not touching. So here we're touching it, but here we have oversized 20, but here we don't have oversized 20, maybe like 5% only here. So the seal is not very strong. So this way, we need to do an Indo anchor. So this one is the only time where we indication to do an Indo anchors to strengthen your repair. So Indo anchors, when the company tell you, they tell you the neck 4 millimeter, but they don't tell you about this number. Because 4 millimeter is very misleading. You cannot do Indo anchor for 4 millimeter neck and no sealing zone. So Indo anchor for neck 4 millimeter and sealing zone 10 millimeters. So you still need sealing zone 10 millimeters. Then you do an Indo anchors and you get an excellent result. How the Indo anchor work is like a suture line. This is the way it works. They penetrate the wall, you see? And you have to put it circumferential. It's very similar to the aortic repair, the surgery. Why is that? If you look at all the repair, the EVAR, we do them, they give you all longitudinal strings. So because they have a hook, they prevent the graft from going down. But none of them, they give you a circumferential or radial fixation. So all the stent give you only longitudinal fixation. None of them give you radial fixation. So the only one give you both is the Indo anchors. So the Indo anchor give you longitudinal and radial fixations, both. This is how they work. You see, they go through the wall, and then you have the aortic wall. You do the anchors. You do first time. If you're happy, if you're not happy, you can pull it back. Then you go again. If you are happy, then you press again and just go through the wall and fix your aorta. Is the way it works, you know. And it only go 2 millimeter inside the aorta. Look how enough here. This is they try to pull it. You see how strings give you a very longitudinal fixation. This is the Indo anchor. See how it try to pull. And the most important, again, give you a radial fixation. Like here, if without Indo anchors, usually the neck diet with the time. So when the neck diet with the time, the graft will separate from the aorta. But if you have an Indo anchors, even if you get that in the future, you see the graft still attached to the wall. So the Indo anchor prevent type Indo leak when the neck diet in the future. So it's the advantage. And even some people said it's better to use as prophylactic. But the only reason why people don't use prophylactic because it's a very expensive device. They come in 2 sizes. They come 22, 28 for the aorta and 3 sizes for the thoracic, 22, 32, and 42. Not important. The most important contraindication. You cannot use it Indo anchor if you have thrombus more than 2 millimeter. And the reason why, as I said before, the anchor, it penetrates only 2 millimeters. So if the wall away from the graft more than 2 millimeters, then will not touch the wall. And remember, guys, the Indo anchor is like a pin. It's not like a screw. You see, screw will bring things back to it, to each other's. Pin, it just goes through. So even it looks like screw, but work like a pin. So if the wall, aortic wall away from the graft more than 2 millimeters, it will not work. Of course, if you have a calcification, it will not work because no way can penetrate calcifications. And again, if you lose the graft of position, again, if you have a gap more than 2 millimeters, and you cannot use an EVAR system. I mean, it was an iliac. But anyway, this device out of market anyway. But the most important, guys, this 2 millimeter gap. So if you have a type 1 Indo leak and you want to use Indo anchors, you need to measure the distance between the Indo leak, the graft, and the aorta. If you see more than 2 millimeters, or you have a thrombus, big thrombus here, more than 2 millimeters, Indo anchor will not work. Give you some example. This is prophylactic. This is patient, we did it. But even when we finished, was no Indo leak, but because the neck is very angulated, we thought we need to give him some, good fixation. This is another one. This one has Indo leak here. We treat with the Indo anchors and this disappear. There's another guy here. Sorry. Wow, going too fast. Type 1 Indo leak here. But you see it's a big gap. They put a coil here, does not work. But the gap is here big, but here the gap is small. It's okay. You can put it here because Indo anchors are going to be very close to the renal. Even the gap is big here, doesn't matter because Indo anchors goes here. But because the gap is big here, we put an onyx here inside, and then we put an Indo anchors here. After we put an onyx, we put Indo anchors, and it works really very good. And you can see Indo leak is gone, and this is follow up CT angiogram, and you can see the anchors here, and you don't see any type Indo leak, and you can see no leak here. Another patient came again with type 1 Indo leak, and put in couple Indo anchors, and we see the Indo leak here is gone after putting Indo anchors. Another patient, but this one, but this one, you see the graph move down. So Indo anchor will not be enough. Here you have to put scuff because you lost the length. And as I said before, if you see a distance between the renal and the graft more than 1 centimeter, 2 centimeters, even if it's no Indo leak, you need to put a cuff because if you leave like this one without repair, with the time this will bulge, and you have a big aneurysm, and now no landing zone. You have to go suprarenal, then you have to do a chimney or BIVAR. Where now it's very easy. You just put another cuff here and put some Indo anchors, and you can seal your Indo leak here. All right. So we talk about, again, short neck, long sealing zone. The most better way to do it is to use the Indo anchors. You can still use a BIVAR or FEVAR or chimney. I'm not saying not, but this is the better way. If you have a short neck, 3 millimeters, and sealing zone is 5, this one too hostile. This is any adequate neck. You don't have a neck, like you see that. Short neck and short sealing zone. So this one, no way you can use Indo anchors here. This one, you need to get more links. You need to go suprarenal. And then you have one of two options. So you need to get a links at least 15 millimeters. You need a good neck, at least 15 millimeters. So either you go with a SHEVAR or you can go with a FEVAR. How we decide to go which one? Of course, FEVAR is much better. It's a custom made. It's considered technology. It works very beautiful. We have a lot of data about it. It needs more time. It needs more expertise. And the most important, take long time to get it at least to our region. And it's expensive. Whereas SHEVAR is off the shelf. It's good for emergency. It's cheaper and technically is much easier. But the problem is that always we have a problem with the gutter leak. So always we have to talk about gutter leaks and how we can solve gutter leaks. So you have both options. You can choose depending on your area and how emergency is the case. SHEVAR chimney, not everyone talk good about the chimney. The reason why they don't follow the rule. You have to follow rules to get a good result with the chimney. Not everyone put a graft stent in the renal and put an EVAR. He said it's a chimney and it looks good. No. The most important first, you still have to need 2 millimeter minimum renal aorta. So you still have 2 millimeter here. If you don't have 2 millimeter, SHEVAR will not work chimney. Then you have to go to FEVAR or open repair. So you still need a short neck, which is about 2 millimeter. This is the first rule. The second rule, you still need a good neck after that, the sealing zone. You need at least 15 to 20. So if you have two renals and they are distant between and you're going to put one chimney, then distance between this renal and down should be 50 millimeters. If less than 50 millimeters, then you have to go higher. You have to go to the SMA. So whenever you have to go, you have to measure from here up at least 15 to 20. And then you see you're going to do 1 or 2 chimneys. So if you're 15 or 20, 15 usually is enough. Get you down to the renal, you can do 1 chimney. But if 15 is not enough, then you have to go higher. Then you have to go to SMA. If the SMA is very low, then you have to go even higher, and you have to go to the celiac. But now you have 3 chimney, it become very problems. So maybe it's better to use BEVAR or FEVAR. Usually 2 chimney is very acceptable. 3, you're pushing the limit. 4 chimney is too much, unless you're dealing with the thoracoabdominal aortic aneurysm. So again, this is a rule. You need 2 millimeter. The most important, the new neck should be 15 to 20. The second thing, the angulation. There's a very restricted IFU for SHEVAR. The infrarenal neck, the lengths, again, we said 2 millimeter. The new thing, we talk about it. Here, the angulation. The infrarenal neck should be less than 60. This is here. The suprarenal should be more than 45, less than 45. And the suprarenal SMA angle should be less than 45. Also, this is important within the IFU. And the renal angulation should be less than 90 to get a good result with the chimney. So this is all important IFU. You have to follow them to get a good result with SHEVAR. Oversize is very important. You need to oversize at least 30%. If you over 15, usually we do it, or 20% will not be enough. 40% is too much. So the most important between 20, if you use 1 chimney, 25 is enough. If you use 2 chimney, you need at least 30%. The other way, if you calculate it, you see how many chimney, like maybe if you put like 2 chimney, you add them and you divide them by 2, and you add them to the diameter of the aorta, and you get the size of the graft. Let's say you want to put 2 renals, and each one you're going to put like 6 millimeter graft, stent graft in the renal, and you have 2 renals, so 6 plus 6, 12. Divide by 2 would be 6 millimeter, plus like 24 aorta diameter in this area, so 24 plus 6 would be like 30. So you need the 30 millimeter graft. So you can use this formula, or you can use just oversize between 25 to 30% to prevent type 1 endoleak. Let's give you an example here, like of chimneys. You see it's very short neck here, 4 millimeters, and you can see very wide here is no sealing zone. So we end putting 2 SHEVARs and then stent graft and did fine. So just to summarize it, guys, if you have a long neck, long sealing zone, do SHEVAR. If you have a short neck, long sealing zone, I think called hostile neck, I think Indo ankle will work fine. If you have a short neck, short sealing zone, we have inadequate neck, then you have to do a SHEVAR or go with a BEVAR or FEVAR. Yeah. Before we go to the conical neck, any question about the short neck? Because this is the most important part, really. Any question from you guys? Or about whatever I said? Unless we didn't understand anything. No question? Is everything clear?
I'm sorry, I joined 10 minutes later. I'm sorry, I joined 10 minutes later, but I didn't catch the difference between sealing zone and the neck.
Okay. We can go through back again. It's okay. Let me see how I can go back. Okay, too much going back. Let me see how I can get it out. Oops, what happened? Sealing zone. Yeah. Well, let me draw it for you guys. Maybe it's better. Because if I draw it, do you see my paper? You see my screen, right?
Right.
Okay. Let's talk about, give you Okay. The water. Whatever, here is okay. All right. Let's say the aorta size here is 22. 22. Okay. And the length here is 15. Okay. This is very good neck. 50 millimeter, 20 straight one, 22, 22. Let's say it goes 26. If you use 26, graft. So when you put 26 here, you put 26 here. So here in this area, you're oversizing 15 or 20%. 20%. Oversize here 20%. Here over 20% here, 20% here. So you're oversizing always 20% here because same length. So over the length of 15, you're oversizing all 20%. Okay? So this is called the neck. All right?
Yes.
And this one, the sealing zone, the same. 15 millimeter, again, you're oversizing 15. The wall is an aneurysm still touching the wall. So it's called a sealing zone. So also sealing zone here is 15. So here, sealing zone and the neck are the same. Okay? Maybe later on you can understand more. Let me do another one so you can understand. This is short neck here, like this one, this way, like that, and you're going like that, aneurysm. All right. So this one, let's say here, it's 22. And here is 25. Okay. Okay.
Yes.
And here, for 4 millimeters, still 22. After 4 millimeters, 22. Okay.
Okay.
Here, become 24. Okay.
Yes.
Okay. So when I go and put a graft here, sorry, like that. Okay.
Yes.
Here, up to the 4 millimeter here, we have 20% oversize. Okay. So this is a neck. This is what called a neck. Because we have 20% oversize. Here, the graph is still touching the wall. You see, it's touching the wall because 26, the graph 26. I'm using 26 here, okay?
Yes.
Here, 25, so still touching the wall. But is 25, if you put 26, you're not oversized 15, you oversize maybe 5%, correct?
Yes.
But still touching the wall. So as far as touching the wall, this we call the sealing zone.
Yes.
But the sealing zone is not, we're not oversizing 10 or 15%, it's just touching the wall.
Yes.
So that means here we have a seal because blood will not go anywhere because the graft is still sealing here. But the seal is very weak because we don't have 15% oversize here. So this can slip anytime. The reason why here you need to use an Indo anchors.
I got it. Yes.
So this is what we call, so here we have a 4 millimeter neck, but we have 15 sealing zone. So you still need, or 10, you still need 10 millimeter sealing zone.
Yes,
if you don't have 10 millimeters sealing zone, if it's still like, if this one, let's say here, 28, okay? Then the water is not touching here, so the graft will not touching here. So your sealing zone end here, so it's very short. And this from here to there, only 8 millimeters is not enough.
Yes.
So if you have a neck 4 and the sealing zone 8, will not be enough. To do the endo anchors, you need 4 and you need at least 10. So you have to go up down to 10, and then you measure your diameter here. If it's still less than 26, you are in sealing zone. After 10 millimeter, is the neck more than 26? It's not a sealing zone. Then you don't have 10 millimeters. Okay?
Yes. Yes.
And this take me to the third one, which is like that. You understand better now, you see? Okay, so here when you put the graft like that, so you still have a neck here, 22 and 22. So he's 26. You still have 4 millimeter here, right? But when you want to go 10, you go up to here, 10. Here is like 32. Correct? So he is not touching the aorta. So you cannot say I have 4 millimeter, I can use Indo anchor. It will not work here. You see, this is not enough because you only have a short neck, but you have no sealing zone. You see, sealing zone 10 millimeter is not here.
Yes.
So, you know, so this one have short neck, long sealing. This is short neck, no sealing. So this one you have to go higher because you need a neck. There's no neck here. Then you have to go up to here with your stent, with the EVAR.
Yes.
Okay? And then either use a chimney here or you do a BVAR. Or FEVAR, sorry, FEVAR. Use a FEVAR here with the fenestration.
Yes.
So there's a difference between them. It's a way how you can decide, okay?
Yes, thanks. It's clear.
Any other questions? All right, looks no other question. Let me go to the, where is the sharing? Share, resume sharing. Stop sharing. Let's go to our lectures here. All right. You see a slide again? All right. The conical neck. Now we could talk about conical neck. It's generally increased in diameter for up to 4 millimeter from the top to the bottom. This is by definition. This increases your child's type 1 Indo leak. So how are you sizing? This is 2 different neck. Like this one is very dangerous because the graft can slide down very easy. This one also conical, but this is much better because you have a sharp neck here will hold the device from going down. Okay. But whatever you put here, always you have to use this one as a sealing zone. So even here, like let's say 22 here, 25. So you have to 26 to use at least. And if you use like 24 and here 25, you're not sealing. You have to get this whole neck sealed. So what usually we do, some people, they measure links here, and they take the, you know, the median and they oversize 20%. Or you can go up, down. You do, what I usually do, I do 15% here. I go 10 millimeter. Here, I measure the neck here and go to 15. And here I go 20%, sorry. This one I go 20%. I go 10 millimeter down, measure the neck here, and I go 15 millimeters. And then I try to get what the numbers close to them, you know? And this way you can decide what to use, you know? But always go with the oversize, you know, and always be sure that at least the graft will touch the wall at least for 10 to 15 millimeters. If you have an angulation, maybe you need 20 millimeter to be touching the wall. All right? Thrombus and calcifications is an issue. The problem with the thrombus, it can embolize the renal artery, because especially when you do ballooning, because you squeeze the clot goes up, migration, and proximal type 1 Indo leak. So most studies or most paper or most, you know, device that you don't use if you have a lot of thrombus. But is there any evidence? Not evidence really. It's a very nice paper. They look at the thrombus and they found it's no different in the short or long term. So don't get afraid of the thrombus, you know. But the only, they have to follow a special rule. The first one, have the graft in place before angiogram. This one, you don't deploy the graft too much above the renal, just a bit above the renal, because you don't want to move the graft too much because you can embolize, you know. Deploy the graft starting at a little bit higher, not too much, and bring it down, as you said. Get it right from the ones. Don't keep going back and forth and play with the wires. And the most important, no ballooning. We don't balloon when you have a clot. Unless you have type 1 Indo leak, then you have to be very careful, very gentle with ballooning. But on our EVAR, all of them we do prophylactic ballooning. All of them we balloon, except when you have a clot. I don't do ballooning unless it's type 1 Indo leak. So when you do blood, you do an angiogram. If you're happy, stop. Don't do ballooning. If you see type 1 Indo leak, you have to be very gentle with the ballooning. And again, decrease wire and catheter manipulations. Angulated neck. This is the fourth problem with the neck and angulations. And you can see that, like 90 degrees. The old device, I said you cannot use it, but now the new devices, even with 90 degrees, can still use it. The most important to fix your C-arm. Oversize 20%, very important when you do an angulations. This is very important. Adjust your C-arm. Because in angulation, you don't go, you need to go lateral, so you can be sure you took the whole length. Because if you go like AP, you lose a big length of the neck. And the reason why I'm saying that, when you dealing with angulation, you need at least 15 to 20 millimeter neck, because you're going to lose a big part of the neck, you know, when you deploy it. So when you do central line, everything looks like straight. So you look, oh, I have like 10 millimeter, looks fine, but it's not true, because when you deploy it, this 10 millimeter, you're going to lose at least half of it with the angulation. So you end with only 5 millimeter neck. But if you start with 15, then you lose at least 5 millimeter, then you still have 10 millimeter neck, you'll be fine. So don't do severe angulation with a short neck. It has to be a really long neck when you have a severe angulations. Sometimes you cannot push the device through, you can use through and through wires, which is, guys, and sometimes you can use a palma stent if you have a type 1 Indo leak after because of the angulation. This is how you do through and through. You go from the femoral, or you go from the brachial all the way down, and you snare it and you pull it down. And this is, then you pull the wire from both sides, and if you have a severe angulation, this will help you the device to go through angulation all the way up. The only problem, guys, when you do that, it's very important to put a catheters here over the wire all the way to the aortic arch here, and leave a catheter. If you just put a wire and you pull, it can be like a cheese cutter, so you can damage the origin of subclave, and you can get to major bleeding. So when you go from the brachial, put a catheter, like verb catheters, all the way up to here to protect it, and then you pull the wire. But don't pull the wire without putting a catheter inside, especially in this area here, because this is angulation here. This is how to do palma stent, like this one. You see, huh, guys? You see, because of the angulations, get a type 1 Indo leak. So you go and put a palma stent. Palma stent will push it because it's very stiff, and push it back, and then this will help. First, you try ballooning itself alone. Sometimes be enough, but if ballooning is not enough, then you put a palma stent, and this will help you to get the type 1 Indo leak fixed. This is very important, guys, when you deploy it. When you have an angulations, the most important is that when you're ready to deploy it, when you put at the level of the renal, take the stiff wire out, because the stiff wire keeps the graft up. You want the graft to turn down, so it takes a curve. So the most important, if you have severe angulation, and we do this trick a lot, is that before deployment, when you are thinking at the renals, you take the stiff wire, either you put no wire or put a soft wire, so that then the device will bend, and then you deploy it. And after you deploy it, then you put the stiff wire back. The graft high and again, very important to deploy the graft up and go down, because the angulation, no way you can push it up. So always you have to be sure you are up high in the level. If you miss it and it went down, no way you can push it up, especially with severe angulation. So always start really up high and go slowly down. Remove the wire, let the angulation take its place, and then complete deployment. And again, don't forget to put the wire back if you took it out before deployment. The second thing is that, especially when you deal with Medtronics, because it has a cone, with the angulation, you see the cone usually stuck with the angulations, and sometimes it's very hard. And if you pull it back, the cone, it may pull the device down. So you have to be very careful. So what usually you do, you can remove the stiff wire again to make the cone more flexible. But the other option, you go from other side and put reliant balloon, and you inflate the balloon. This will push the device away from the wall of the aorta, and you'll be able to pull the cone out. But this is very common problems if you're dealing with the capture device like Cook or Medtronics, because they have a cone, you have to pull it back, and you have angulation. Again, to see the cone is just hooked to the graft, and you cannot pull it down. The only way is to put a balloon from the other side, and you push to the side, and then you can pull it down. If you're dealing with Gore, you don't have this issue, because Gore doesn't have a cone. in experience center, EVAR V angulation is safe, result equivalent to the match control, no type 1 endoleak migration, standing graft rupture, or AAA mortality. So even severe angulation, you can still a good result, but you have to have a good neck. Okay, before we go to neuro aorta, any question about any problem with the neck? So we're done with all problem with the neck. Any question? No question. Okay. The second challenge, we talk about changing the neck. Now we go change to the bifurcations. Definition narrow if less than 20. This is by a few, but up to 18, I think is acceptable. You can do it even with the 18. Less than 18, I think you're pushing the level, you know. So like 16 is really narrow, but 18, 19 is acceptable. Why is that? Can cause lip occlusion. And usually it's contraindicated when used bifurcated graft. So what's the solution? Napkin ring aorta, cracking of circumferential narrow aorta with high pressure kissing balloon. So you can do that. But guys, don't do that before putting an EVAR, because if you crack it, you may rupture the aorta. So if you think, and if it's circumferential, it'll be very hard. If it's like, you know, half circle, then yes, you can crack it. But if circumferential, it'll be very hard. You have to be very careful. But again, if you decide to use high pressure balloon to crack it, it has to be after doing the EVAR. If something rupture, at least you have an EVAR inside, you know. So it's what usually you do. Sometimes you need to put bilateral stent, especially not the self-expand balloon expandable stent, because the stainless steel are stiff. Also to keep the bifurcation wide and open after you crack them with the balloon. And the last solution to use an aortic iliac, and this is the safest solution, to use aortic iliac, block the contralateral limb, and do fem-fem bypass. This is the safest way, especially if you're dealing with like 14, 16. If you're dealing with 17, 18, I think you can crack it. But if you're dealing with like 14, 16, I think it's too much. Then most of it you have to use aortic iliac graft. The good thing now, or the other option, you use endologic. And we don't have it in Saudi because endologic, it has no limb. The limbs sit at the bifurcation. So you don't have a two limb, you know, fighting for narrow place. But even this one, you know, we don't use it in Saudi. I don't know if in Egypt they use it, guys, or not. But this other solution. And the last solution, which is already came very soon, very recently, is called ingraft, because ingraft is very low profile. And you can, and if you look at the eye view, they don't have any eye view for aortic bifurcations. So you can use it up down to even 11 millimeters. This is what the company said. They said you can use it for 11 millimeter aortic bifurcation, very narrow aortic bifurcations. And I went there, I took a course on this device, and I put that, and he brought me a syringe, 10 cc syringe, and he put two limb, and it looks fine to me. So this is something you can consider it. Why? The reason why is that because first, this is a narrow, this I think 12. And the other things, they are both the same size. So they don't compete with each other. When you look at the other company like Medtronic, Gore, Cook, usually the ipsilateral and the contralateral are different size. One large, one small, or vice versa. So always the large one can compress the small one. The reason why you need enough space, so none of them will compete for the space. But if you have them both the same size, then you don't have this competition. Both, they will take the space assigned to them equally. And this is the idea behind the ingraft. But according to them, you can use it even down to the aortic bifurcation, 11 millimeters. Okay, any question about bifurcation, aortic bifurcation?
Hi, Dr. Qusair, how are you?
Yes, go ahead, please.
I just want to ask regarding for the aortic bifurcation. It's very calcified. What do you think about intravascular lithotripsy in this case? Because you're basically cracking it without using very high pressures, and you're basically minimizing the risk of rupture. Have you used it in your practice?
Not really, but I saw a couple of cases it worked very good, really. Yes, I agree with that. This is something, but again, I mean, you crack the calcium, but if the aorta is still narrow, as I'm saying, I mean, you can crack it again. You can compromise like 2-3 millimeters, but you cannot tell me like I have aortic bifurcation like 16 with the calcification. You can crack it and you're going to fit. Will not fit. You see my point?
Yes.
So
definitely.
all this it worked, but within 1-2 millimeter out of IFU is 20, but again 18 is acceptable. 17 even maybe acceptable, but lower than that I think is too much.
Okay. Okay. Thank you.
No problem. Landing zone. This is a landing zone. The diameter, the common iliac artery should be between 8 to 20 or 22 because the largest one we have is 28, but I think it's too much. You need at least 2 centimeters. That's what the company said, but I don't agree with that. You need at least 3 centimeters. You need 30. 20 will be short. So you need 30 millimeter. You have tortuosity, stenosis, and oversize 10 to 25%. I mean, you don't have this legacy really. You have to choose a size according, because there are only few sizes. So you just go to the size which is larger what you pick up, you know. We talked about that before. So if you have aortic aneurysm, common iliac artery aneurysms, well, how going to treat it? You have 2 options. Either we can use, we can close one iliac, and so extend it, and then we can do an iliac branch device, or we can do chimneys here. So these are the options, you know. Now, most people, they like to keep them both because most studies showed even including one iliac, especially young people, can increase your impotence and beta claudications, you know, and even chronic ischemia. So nowadays, even including one, they don't like it. They like to keep both internal iliac open. So if you have a legacy to keep them both open, do that. If it's not, at least keep one of them open. The people, the most common device is of course the iliac branch device, which is common now. It's available. It's off the shelves. But also chimney work very good. The chimney. We did a couple of cases, and we just published our paper, like I think published like yesterday, about how you size chimney for iliac. I try to put the paper in the group because you have to do a special sizing to get the tightness here correct, so you don't get much Indo leak. But even with the chimney, you get an Indo leak. The difference from iliac and aorta, you see, the aorta problem has a lumbar. So when you have a type 1 Indo leak, the blood go in and go out. You see, the blood, if you go in only, then this will be thrombosed, will not get an Indo leak. The reason why when you see a type 2 Indo leak, you're going to see 2 lumbars. If you just see 1 lumbar, it doesn't make sense because if the blood go in and no place to go out, it's going to thrombose. But if you see type 2 Indo leak, it's continuous type 2 Indo leak, you have 2 options. Either the patient has 2 lumbars open, or maybe have 1 lumbar open and you have type 1 Indo leak, which you don't see it. Because the blood has to go place in and out, correct? So always you have type Indo leak, 2 Indo leak, look how many lumbar. If you have 1 lumbar only and you still have persistent type 1, type 2 Indo leak, look for the sealing zone here because, or down, most of you are leaking from somewhere else, okay? So why I mentioned that, because when you come to the iliac, is different. Iliac has no branches here. So you sealed from here, you sealed here, you sealed here. So even if you get some type 3 Indo leak between the chimneys, if you come after a month, this will close because blood has no place to go in here and has no place to go here, so it will thrombose. So when you do compression angiogram, if you see some gutter leak here, don't worry, this will thrombose later on. So don't worry about it much, okay? So this is about the iliac aneurysm. Other option to use a flare, like if wide here, you can go up to 28, but I will not advise that because it's like an aneurysms. So usually I don't go more than 20. So that means the largest iliac should be like an 18, then I can use 20. If the iliac more than like 22, 23, you can use 24 or 28, but it's not advisable then because you're dealing with aneurysm already. But if you have it and patient is old guy, 80 years old, and just won't get through the case, you can use still flare limb And again, they come 24 and 28. Any question about the iliac? No. All right, access vessel. Sometimes you see the aneurysm, it looks beautiful, like nice neck, nice landing zone, nice bifurcation. Look at the external iliac, and they are like 5 millimeter and calcified. You know, this is the worst things happens, you know, because everything looks perfect, but you don't have an access vessels. So it could be narrow, calcified, stenotic, or tortuous. Or tortuosity. Look at that. How about tortuosity? And you see that a couple of times. You see like beautiful aneurysm, beautiful neck, beautiful landing zone, but look at the access side here. You see, that challenging. If you have an obese patient, especially if you do an open repair, it's better to get the graft from here. So because it's very hard to go 90 degrees, especially if they're very obese patients, you know. So it's better to perform incision here, and you put your device from here, so be less angulation when you go in. But nowadays we do most our, you know, EVAR is percutaneous. Really, we don't do open rarely. The second thing, if you have an iliac narrow, go to other iliacs. You know, if both are narrow, you can always dilate them. But if the whole iliac is diseased, then you cannot. Then you have to use a conduit. And if you decide to go on conduit, you just do a flank incision. You do a conduit, but it has to be at least 10 millimeter diachrome graft. Don't use less than 10 millimeters. So use a big graft. And after this one, either you ligate it or you can use it as an iliac femoral bypass. It depends how it's iliac. If the iliac artery is very bad, you can use it as a bypass to the common femoral artery. But use a diachrome, which is really I use a diachrome. The most important, guys, if you have an iliac stenosis and you balloon it, and even if you see a dissection, don't stent it now. Because if you stent it now, when you put a device at the stent, it may move with the device. So my advice, ballooning now, even if you see dissection, no perforation, of course. See dissection, don't worry about it. Keep going with your EVAR. After you finish on your way back, you put a stent for the dissection. But don't try to put a dissection stent before you put an EVAR, because it's a fresh stent, a mostly tight area, so it may capture with the EVAR device. Okay, let you have a rupture is a different story. Tortuosity, if you iliac tortuosity, like with this one, you can do through and through, as we talk about it, through and through, or you can use what's called a body wire. You do 2 stiff wire, and this helps you to straighten up the iliac bifurcations. All right. Complication, iliac on a stick. This is, I think this is one of our patients. This is an early experience where the iliac was very tight. And when we are pulling the device, the whole external iliac artery came out. We call it iliac on a stick. And you do an angiogram and you have a perforations. The most important, keep your wire. As far your wire is still in place, don't worry, you can fix it. Okay? So the first thing, you go from the other side, you put an occlusion balloon because you want to stop the blood flow here. Okay, retrograde flow is not a big deal. The most important, you have to stop the high flow from here. So go contralateral, put occlusion balloon, do your angiogram here, and you put a cover stent if you have a good landing zone. So the most important, if you lose the wire, then it has no other. Then you have to open. You know, then you do a flank incision. It's very easy, and you repair it with a graft or whatever you have to do it. You know. And don't worry about internal iliac. If you need to cover it because you need more landing zone, this is more emergency. So cover internal iliac. Don't worry about it. Now your priority is to seal the bleeding. And always you can do an open repair. If patient become unstable, just very easy, very small flank incision, because the hematoma will do dissection for you. So the moment you do a flank incision, you put your hand, you are in the external iliac, because the hematoma already dissects for your retroperitoneal space. So the moment you open, you dissect the muscle, you are retroperitoneal, you open retroperitoneal, and you are there right away. So you put your hand, squeeze it, put a clamp, and fix it, or do bypass, whatever need to be done. All right, so increased number of patients referred to EVARs out suitable anatomy experience center. Always you have a lot of tools to fix them. Again, guys, don't go more than one unfavorable anatomy. You know, again, you can have an angulation, but don't have angulation and thrombus and calcifications. Don't mix unfavorable anatomy, which are others. And open repair, guys, always an option. Don't forget that. Sorry. Open repair. So if you have a short neck, short patient is good candidate for surgery, go with surgery. I mean, open. We are still a vascular surgeon. And this would be my advice. If you go out of IFU, because remember, when you go out of IFU, you're in your own risk. The company will not support you. And so if you decide to go out of IFU and deal with these challenges, then you're on your own. If you don't feel comfortable, just don't open repair. Nobody will blame you for that. I think that's all. Any question, guys?
Yes, doctor, I just have a couple of questions about the endo anchors with the hostile neck.
Okay.
So the first thing is when you are putting your endo anchors, my first question is how many endo anchors do you put? And my second question is, so when you're putting your endo anchors, do you put it like the highest possible at the neck, or basically at the seal zone? Do you go down and put it at the start of seal zone, or that doesn't matter?
Okay. Is the only question? Any other question?
Yes, these two mainly.
Okay. Endo anchor is a big. Let me see if I can find the lecture, because I have a complete lecture about endo anchors. Because this answer all your question. Let me see if I can find it very quick. All right, endo anchors here. Let's see, let's go to. All right, yeah, I have it here. Let me share my slide with you guys. Where is the meeting here? You see my slide?
Yes.
Okay. First question, how you do that? This is show you how you have to do it, you know. First, if your neck is less than 28, you need at least 4 endo anchors. Okay? This answers your question.
Okay.
So if the less than, at least, always come with a 10. The device comes with a 10. You can put more, no problem. The more you put is better. But the minimum should be on a 4. How you do that? You do an LAO 30 to 45. Okay? Then you put 2. Then you twist it. It doesn't move, sorry. Then you go RAO. So you put LAO. Okay, so LAO, you put 1 here, and you twist it with another 1 here. Okay? Then you go with C-arm, RAO, 30 to 40, and then you put 1 here, and then you twist your C-arm, endo anchor, you put the second 1 here. So you end with putting 4. If you are dealing with a big one, 29 and above, like 30, 32, 35, whatever, you put 6. And let me see, does this work? No, it doesn't work. Again, you go first 30 LAO, you put 2, 1, 2. You go another RAO 30, you put another 2. Then you go 90 and you put 2. So you end 1, 3, 6. Okay?
Okay.
Minimum.
Okay.
If you have a leak like this one, then you just go and put around it. Does it work? No, it's working today. If you have a leak, try to put most of them around this area of leak. Then you can put here. But the most important, concentrate on here. You put 1, 2, 3, 4 around the area of leak. Okay?
Okay.
The most important, when you deploy it, it has to be 90 degree. You cannot, you see the circle here? You should not see a circle. It should be like an L shape. So you have to twist, but here not 90 degree. You have to be 90 degree on the wall to get the device like that. Okay? The second thing, you have to use the right size. As I said, it comes in 2 sizes, 28 and 30, 26, 28, 28, and 32. Because if you have a short, a small one, a large neck, then when you push, this device will go back. So you don't get penetration. So you have to use the right size of the endo anchors to get a possibility to go through the wall. This is very important. Okay? This is the tips. The first one is that you need at least 5 millimeter neck. We talk about it. So if there's no neck, because you need a place to put an endo anchors. So it doesn't mean how long is the sealing zone. The neck, which is, as I said, the short, it has to be 5 millimeters. Okay?
Okay.
You need to put it very close to the renal artery. Don't put it in the sealing zone. No, you put it very close to the fabric. Where very close to the fabric, where the fabric touches the pear stent. So it has to be very close to the renal and very close to the fabric. Because after that down, the aorta is far. You see, if it's the aorta far 2 millimeter, then you cannot go through. So the most important to put the first row around the fabric, very close to the pear stent, close to the renal artery. After you put it, you can put a second row under it if you want, but don't go too far, because again, you have 5 millimeter. This is where you want to capture the endo anchors. If you put them very low, like 1 centimeter, then they will not capture the aorta. Okay. Do the ballooning first. Before you do it, always do ballooning, because balloon will push the graft to the aorta, make it closer, and this will get your endo anchors to penetrate better. Size, again, according to the endograft size. This is more difficult for arch. Contact, penetrate, anchor the proximal fabric edge. See, the proximal fabric, very to the proximal. And you can use 2 row, but again, 1 row is acceptable. And Ham said to do circumferential. Don't put only one area. Try to put your endo anchor circumferential. The reason why you need to use C-arm, RAO, and LAO, and then 90 degree. This is just the cases. So again, you see, you need to put them here, very close to the fabric. I don't know if you have cases, you can see them in the cases. Like you see, the first row, it has to be here. You see where's the end? It has to be here. This is the second, because this is a leak, I'm putting a lot of them around the leak. But usually it has to be in this area here, very close to the tip, like this level. Okay. Let me see if I have better pictures. No, this is just data. Yeah, here, like here, you see here. So this, even this lower, I will go a bit higher. It has to be, you see the dots here, it has to be here in this area here. Very close to the end. Because if you go down, again, always afraid you are far, maybe the aorta is here. So always you get, because the only time the aorta is very close is in this area here, because it's your neck. So you put them like very close. See the tip, they are here. Okay? So let's answer your question. Any other question?
Thank you.
No, okay. No other question? Okay, guys. What do you like to do next week? Do you want to speak about critical limb ischemia or complication? We can talk about complication, what could happen during EVAR, so you can finish from the EVAR completely. Like if something like you write too high, what you do. If you write too low, what happened? If you nail the, you know, the limb. Yeah, and I think it's very important. I don't know if it's important or not. Or we can talk about critical limb ischemia if you have enough of aorta.
Is it fine if we can see a couple of cases of iliac branch device or chimney for the iliacs?
Yeah, but how you can see them? I don't record them, you know.
Okay.
I can give you the steps how you do them, the EVAR. I think is an important how you do, because you have at least like 12 steps, you know, how you do a EVAR. And how you deploy it first, how you do an EVAR first, how you do stent, how you pull that. I think it's a good, we can talk about it, EVAR. Because this is, guys, I'm trying to find something you do it, you know, because in your practice, especially in this area, you don't have EVAR and BVAR a lot. So most of you can end doing an open or doing a EVAR, you know.
Yes.
So I think you need to know how to do EVAR correctly. And again, I put a presentation. I think you have at least 10 steps how to do a EVAR. Let me see if I still have it. Hopefully I haven't. EVAR. Anyway, I'll look for you guys. I'll look for it. And then yeah, like that. You can see my screen. You see my screen. So you see here EVAR.
No, it's still the endo anchors presentation.
What about endo anchor? Sorry, let me end it. but I don't want to talk about it now. But we can. This is, you can see now the shiver.
Yes, yes, we can see.
You see how many 2, 3 the steps, how you do it, what you have to do. I talk about angulations, how you do see how step, how you put them first, and how you do it step by step. So if you're interested in that, we can talk about it next week. So is that
Okay.
something you want to talk, guys, about aorta again, or you don't have enough of aorta? Anyway, let me know in the group, guys, what do you want to do next week, or you want to go back to the questions, up to you. I mean, I'm open for anything. All right. People say chimney is great. Looks people, they like a chimney idea. Let me see some messages here. Critical limb ischemia, about Indo-leak treatment. Chimney is great. Yeah, Indo-leak is important. But I'll leave it to the end, because Indo-leak always you can send to our friend interventional radiologist to deal with it. But it's an important. Critical limb ischemia is important. Chimney is good. So let's talk about chimney next week, next Saturday. Well, hopefully it'll be Saturday. We can talk about chimney Saturday, so we can finish with the aorta before we go down to the critical limb ischemia. All right, guys. Have a great night and see you Saturday, hopefully. Take care. Bye.